Shannon, are we ready to get started?
Yes, Nicole, you want to go ahead and do the intro?
Absolutely. Good morning, everyone. Welcome to VCU's Cardiology Grand Rounds. It's my pleasure to introduce the speaker, one of my mentors today. Dr. Henkin is a cardiologist specializing in vascular medicine and professor of medicine at Mayo Clinic in Rochester, Minnesota. He completed medical training at Boston University School of Medicine and then pursued both internal medicine residency and vascular medicine fellowship at Mayo Clinic. After that, he then went on to complete cardiology fellowship at Dartmouth Medical Center. Dr. Henkin's clinical focus includes management of aortic disease, including connective tissue disorders, spontaneous coronary artery dissection, and associated arteriopathies, management of venous thromboembolism, and cardiovascular optimization of patients with polyvascular disease. His research includes prevention and management of postpulmonary embolism syndrome and cardiovascular outcomes in patients undergoing vascular surgery. So with no further ado, Dr. Henkin, thank you so much for joining us today, and we'll go ahead and get started.
Well, Nicole, it's so nice to see you, and very nice to see everyone virtually. I'm delighted to talk to you guys today about ascending aortic aneurysm. I think a really under-recognized and under-treated entity in cardiology. Let's go ahead and get started. I don't have any disclosure. These are our learning objectives that you saw earlier. We're going to talk about etiologies of ascending aortic aneurysms, methods of surveillance, and thresholds for repair, and we'll take a look at where all this data comes from. So I want to start off with the case. These are real cases in clinic. This is a 57-year-old woman who is referred for ascending aortic aneurysm. She has a past medical history of peripheral artery disease and COPD, and she's a significant prior smoker, quit just a few years ago. So this is a non-con CT of the chest that was obtained for lung cancer screening purposes. And you can see incidentally what's discovered here is a 5.8 centimeter ascending aortic aneurysm. So when I see her in clinic, we start talking about things, and she tells me, I've been really tired for the last couple of months. She's been having night sweats and weight loss as well. No headache, vision changes, or jaw claudication. On exam, she doesn't have any murmurs or bruits, no temporal artery tenderness, and her radial pulse is normal. So we get a CTA, chest, abdomen, pelvis with contrast to evaluate her vasculature and understand her true aneurysm size. And what you can see here is that with contrast, her aneurysm measures about 4.4 centimeter, and there is circumferential thickening that's quite significant around the whole aorta. There is that sign, the pointer right there points you to that circumferential thickening, both ascending and descending aorta as well. We then get an echocardiogram, and her echocardiogram, leading edge to leading edge, shows that her ascending aorta measures around 4.8 centimeters. And I measure here for you the thickness of her wall, and her wall is measuring at 0.4 centimeters. So actually quite thick as well too. So you can see where that initial measurement of 5.8 centimeters may have come from. We then get some lab work. She has an ESR of 80, CRP of 18. Her IgG is normal. We're able to diagnose her with giant cell arteritis. She started on prednisone and tocilizumab, and she does much better. A couple of months later, her follow-up imaging with much less mural thickening. So think about that case number one. Here's a more common case in our clinic. A 49-year-old presents for evaluation of dilated aortic root. She is very active without symptoms. Normal blood pressure and heart rate on exam. She's tall. She has a pectus excavatum. Talk about what that means. She has a positive wrist and thumb sign. She's on no medications at this point. And when you talk to her, she says, yeah, my mom had an aortic dissection at age 45 and had to have emergent surgery for that. This is her echocardiogram. You can see that her aortic root, leading edge to leading edge, is measuring around 4.7. She has a tricuspid aortic valve. The ascending aorta is not well visualized. And when you compare it to an echo a year ago, her aortic root has grown by about 4 millimeters in the same measurement. We obtain a CTA, chest, abdomen, pelvis, and you can see that her aortic root, sinus of Valsalva, is measuring about 5 centimeters by 4.4 centimeters. And so really important to compare to prior measurements, and on prior measurement a couple of years ago, her aortic root was measuring 4 by 4.4, so it's grown by 4 to 5 millimeters in multiple directions. So thinking about these cases, and this case specifically, why does she have an aortic aneurysm? What imaging should we use to follow her aortic aneurysm, and when should she be referred for surgery? So I point you to the 2022 ACCHA guidelines for the diagnosis and management of aortic disease. This is a really awesome read and great authors that it took years of compounding research to come up with 285 recommendations in this document. So remember, we have 45 minutes, so we're not going to be able to talk about all the recommendations, but we're going to go through the most important aspects I think that we need to know in our general cardiology clinical practice. But I would suggest that when you have time, you read this document. It's a really great document and really important for our care of patients with aortic disease, both ascending as well as descending abdominal aorta. So when we think about prevalence of ascending aortic aneurysm, the sort of quoted prevalence is 6 persons per 100,000 per year, but this is likely underestimated because there is no screening protocols for this, right? And this is often an incidental finding when we look for other things and find it just randomly there. 60% involve the aortic root or ascending aorta, 10% involve the arch, and 30% involve the descending aorta. And this is what we're going to harp on for much of our presentation. Up to 20% of thoracic aortic aneurysms are associated with inherited disorders, bicuspid valves, and familial predisposition. So we need to think about familial predisposition and inherited disorders with every thoracic aortic aneurysm that we see and have it be more as a rule-out diagnosis rather than a rule-in diagnosis. And even thinking about a definition of an aneurysm, we remember from medical school, we learned that the definition of an aneurysm is an artery that's dilated to 50%, 1.5 times normal diameter. And that works pretty well in majority of arteries, the descending aorta, abdominal aorta, mesenteric vessels, even peripheral arteries. But it does not work well for the root or ascending aorta. So for example, if the normal aorta we say is 3.5 centimeters, then you take 1.5 times 3.5, that's 5.25 centimeters. No one will argue that that's an aneurysm, right? But what if this patient had Marfan syndrome or Loeys-Dietz? Is less than 5.25 not considered an aneurysm? So the current guidelines really do take that into account, and they define 4 to 4 centimeters as dilated. And I would suggest that a lot in the past we've used the word ectasia, especially in radiology reports, instead of dilated. And ectasia is just a confusing term. I've always found it confusing, honestly. So we should be using the word dilated. And when the size is equal to or more than 4.5 centimeters, then we should be using the word aneurysm. So 4 to 4.4 is dilated, more than 4.5 is aneurysmal. But the question that I think comes up as well, especially when we read echoes, is less than 4 centimeter aortic root always normal? And this is from probably something that is in many of our echo reading rooms. This is from the 2015 JACE document. And this takes a look at the aortic diameter, the BSA and the age, and normalizing it to BSA and age. And this sort of 3D structure gives you the 95% confidence interval of the upper limit of normal. So you can see if somebody has a body surface area of 1.8, and they're 35 years old, 4 centimeter aorta may not be aortic root may not be normal. So just because it doesn't fit that definition that's given by the guidelines, don't take it strictly. Take multiple things into effect. Take the body surface area and the age into effect as well. So less than 4 centimeters is not always normal. Now, this is a well-known published JACE document. Something like this doesn't really exist as well for the ascending aorta. So the question is less than 4 centimeters in aorta always normal? And remember, sinus valsalva usually going to be larger than ascending aorta. This is from 2018 American Journal of Cardiology, published from our Mayo Clinic group, and that we use as reference here for ascending aorta, which again takes into account body surface area and age and looks at 95% upper limit of normal. So if you're a 2 meter per squared man who's 40 years old, your upper limit of normal is not 40. It's actually around 36, 37. And in women, if you take a look at 1.75 meters squared and you are 40 to 49 years old, the upper limit of normal here is 34, 35 millimeters. So again, don't get stuck on numbers. Take multiple things into effect. We do have definitions that we can use, but just because the number is not what our definition gives, don't just say, oh, that's totally normal. Think about the body surface area, think about the age, and then decide whether it's normal or abnormal. So as a clinician, we have multiple goals. Our number one goal is to make a diagnosis. Is abnormal aorta, aortic dilation, or aortic aneurysm presence? I believe our next goal is then to define the extent and identify presence of other aneurysms, and that's important. I'll show you why. We then need to identify the etiology and screen family members, critical in our patients. Discuss methods of surveillance and how often we need to surveil, and then think about when this need to be fixed, sort of preventative surgery rather than wait for aortic dissection or aortic rupture to happen. And this is really a multidisciplinary for each goal, multidisciplinary management, because with each goal, there can be multiple different specialties involved depending on the institution and how you structure your aortic clinic as well too. So when we make the diagnosis, as I said, a lot of times this is found incidentally with lung cancer screening or screening for other purposes. So primary care and pulmonary may be the first ones to make the diagnosis. Vascular surgery is also really common specialty that makes this diagnosis because if you are found incidentally to have an abdominal aortic aneurysm and then get a CT chest, abdomen, and pelvis, and then you see, oh, the ascending aorta, the thoracic aorta is abnormal as well. And then obviously in cardiovascular medicine, when we get echoes for our patients or there's some sort of other incidental imaging, coronary artery calcium score, bane of our existence at this point for these incidental lomas. So we see quite a lot of abnormal aortas that are discovered on coronary artery calcium score or coronary artery CT scans. When we think about defining the extent, again, it can really be up to multiple specialties. I think that getting that CT chest, abdomen, and pelvis, and we'll talk about why that is important, and it can be, again, done by whoever the patient follows with regularly. Now, when we think about the etiology, this is where our colleagues in genetics become really critical. And these need to be your friends. If you're not friends with them, you should become friends with them. They are critical to the care of these patients and really now is a standard of care for caring of these patients. When it comes to surveillance, again, it depends on institutions. A lot of places it's cardiovascular medicine, some places vascular surgery, but some places it's cardiac surgery. For example, when I was at Dartmouth, before I took over the aortic program there, it was really the cardiac surgeons that saw these patients regularly. Here at Mayo Clinic, depending on the patient, cardiac surgery may follow some, but usually they don't. It's our practitioners in the aortic clinic. Some places it's primary care because they don't have the subspecialty of cardiac surgery or vascular surgery or even cardiology. We can provide recommendations and then go back to primary care, especially in the rural settings for surveillance. And then when you fix aortic aneurysms, and here I included both thoracic but also descending abdominal aortic aneurysms, it really also depends on institution. For ascending aortic aneurysms, it's really the cardiac surgeons, but for descending and abdominal aortic aneurysms, again, it depends on your institutions and where there is expertise. This could be vascular surgeons. At some places, it's interventional radiology, and some places, interventional cardiologists are also trained in EVARs and even TVARs as well too. So know who your colleagues are when you're thinking about surveillance of these patients and who will be fixing these aortic aneurysms. And when we think about diagnosis, it's like, well, it's easy. Just get a CT scan, just get an echo, whatever. Why diagnosis is easy, but diagnosis is not always easy. And we need to think about the pros and cons of each modality that we can make the definition of aortic aneurysm. So this is a CT of chest, abdomen, pelvis, and there's obvious pros with this. You can visualize the aortic segments and branch vessels really well. This gives you the best spatial resolution compared to all other imaging modality. It is really accurate and reproducible and is widely available. Even small emergency department or urgent care these days have a CT scanner as well, and it's actually pretty cheap. But when we think about cons, There's ionizing radiation. There is a lot of incidental findings that we see that we have then to manage or discuss with our primary care provider, and obviously contrast, especially individuals with chronic kidney disease. Well, what about a different imaging modality? What about MRA with or without contrast? This visualizes aortic segments and branch vessels well and is accurate and reproducible. The other important aspect of the MRA, it does visualize inflammation better than the CT. CT will give you that circumferential thickening, but it's not always the best to visualize. MRA gives you the best visualization of active inflammation. And it doesn't have ionizing radiation. But the issue with MRI is that it's expensive, it's time consuming. Patient cooperation can be key. And patients with chronic back pain, chronic osteoarthritis, shoulder pain, having issues with being in confined spaces, that's a problem. And then obviously, if there is metal present, that's going to give you artifact with some pacemakers and defibrillators. If they're older and they're not MRI compatible, then you can't do this imaging modality. Well, what about the most common modality in cardiovascular medicine, the echo? Well, echo is quick, it's cheap compared to other modalities, including CT and MRI. There is no ionizing radiation, and it gives you cardiac function and valves. But the biggest con with echo is that there is incomplete visualization of aorta. And technical success is not always happening. And as all of you know, that fine motions of your hand, small motions going from different places can give you a lot of discrepancy. And different measurements across time continuum can make echo really difficult as well too. So it's a great screening test to start with, but it shouldn't be our go-to in all cases as well too. And there is quite a lot of discrepancy in aortic measurement. Over time, aorta grows and expands. So that's normal. So it's really important to compare across multiple time points and not only just to last year or 6 months ago. Look at the imaging modality from 5 to 10 years ago and compare it then to now. And we often compare apples to oranges. We'll say, well, compared to a CT scan a year ago, this looks about the same with an echo. Or compared to an MRI 10 years ago, this looks about the same. We shouldn't be doing that. We should be comparing apples to apples, the same imaging modality, echo to echo, CT to CT, MR to MR. Now, CT and MR are more comparable to each other because they're looking at three-dimensional structure in 3 dimensions, but we shouldn't be comparing echo to a cross-sectional imaging modality. But even still, when we do our best to compare the same imaging modality to same point in time, and even when we look at the same point in time, and do this for yourself, do this little quiz sometime. Take an echo, take a measurement of the aortic root or ascending aorta, write it down, go back the next day and remeasure it. Is it the same? Well, this kind of study has actually been done. And this is with experienced radiologists and cardiologists. When you take a look at the same imaging modality with the same radiologist or echocardiographer at different time points, there may be a discrepancy of up to 3 millimeters with the same aorta of the same patient. So know that that exists and do everything you can to take that weakness away. And something that comes into play is that we measure the aortas differently based on our imaging modality. When we use echocardiography, we use leading edge to leading edge, so some part of the wall is measured. So that's going to give you a larger measurement than your inner to inner they use on CT/MRI or sinus to sinus on CT/MRI. And the other thing to remember, and I always discuss this with our patients, when we get discrepancy between echo and CT or MR in sinus of Valsalva, is that we're looking at a three-dimensional structure in really 2 dimensions with aortic measurements and echocardiogram. So especially if there is asymmetry with sinus to Valsalva that we see quite common, especially in heritable connective tissue disorders, you can underestimate and you can be measuring totally different right to left or non to right or left to right than you are on CT compared to echo. So always know what you're correlating to and know that there is naturally going to be some discrepancy because of the measurements when you compare echo to cross-sectional imaging. And the other important things to consider with cross-sectional imaging is contrast versus no contrast. And so with non-con CT, you're measuring the wall plus the inner diameter, and the wall can be 1 to 3 millimeters depending on the patient. So without the wall, you can get a measurement here of 3.4 centimeters. With the wall, it's 3.8. That's a pretty big discrepancy here. And I show you an example of a CT without contrast that's measuring aorta of almost 5.2 centimeters. And based on new guidelines, we should be thinking about doing something about this. But when you get a CT scan with contrast, you can now see clearly that the aorta is measuring under 4.8 centimeters. So CT with contrast is an important first step. The other thing to consider, and this is why ECG-gated CTs are so important, is systole versus diastole. Because again, aorta expands in systole versus in diastole, and you can get a difference of 1 to 2 millimeters. So ECG gating can be really important to understand the correct place, the correct time that you're measuring in the cardiac cycle, and to get the true measurement of the aorta. So things to consider in imaging, and especially in echo, in my opinion, is avoid adjectives such as mild or moderate dilation or aneurysm. That's an adjective that doesn't describe things very well. And as echocardiographers, although we can understand the clinical implication, if this is not our patient and we don't know if this heritable connective tissue disorder, a 4.5 centimeter aneurysm for a 75-year-old man with hypertension is very different than a 4.5 centimeter aneurysm for a 35-year-old woman with Loeys-Dietz. But if we just go based on numbers and we say mild or moderate, that really provides the wrong idea to our referring providers and to individuals who read our echo reports. Remember to adjust for age and body surface area, and this is more helpful for normal versus abnormal rather than give you a true definition, because remember we talked about less than 4 centimeters, not always normal. Compared to same imaging modality over time, so compared to last year, 5-10 years ago, and review the imaging yourself. And this is really important for the fellows in the audience. You need to review the imaging yourself, because how you measure and how you identify these aneurysms that may be missed as incidentalomas. This happens to me all the time. Incidental finding a 4.5 centimeter aneurysm. Everybody freaks out. You look at non-CT, non-contrast CT 10 years ago, it was there. It was the same thing. Nobody just called it. So take a look at the imaging yourself. You will be surprised how many things you will find, and learn how to measure this. This is critical to management of these patients. So the next step is to really define the extent of aortic aneurysms. This is a nice study from Jack from a couple of years ago. This is a cross-sectional population study, and they looked at individuals with different aneurysms and a cross-sectional imaging when it was available. And what they found is that if you have an aortic aneurysm, no matter where it is, if it's in the descending aorta, the abdominal aorta, the arch, the likelihood that you will have an ascending aortic dilation is significantly higher as well too. That may be based because of risk factors, but it also may be based because of familial predisposition or a genetic aortopathy. Or also, if you have an iliac artery dilation, the same thing as well. So, for example, if you have an ascending aortic dilation, then your risk of having an aortic arch aneurysm, a descending aortic aneurysm, or an abdominal aortic aneurysm is significantly larger if you didn't have an ascending aortic aneurysm. So my suggestion, and this is my practice, is to perform one-time whole body cross-sectional imaging, CTA, MRA, to define the extent. And in these individuals, I do include head and neck at least one time as well, especially if there are multiple aneurysms in the aorta present. Or somebody gives you a family history of cerebral aneurysms, strokes, things like that. Think about head and neck imaging as well. So the next step is to identify the etiology. Now, the good news is that majority of thoracic aortic aneurysms, about 80%, are degenerative. And especially descending thoracic aortic aneurysms are often associated with atherosclerosis and its risk factors: hypertension, hyperlipidemia, smoking, diabetes. But when you're considering and seeing ascending aortic aneurysms, really think about inherited disorders. And this is what's different between the most recent 2022 guidelines and the prior guideline iteration from 10 years before that. The prior guideline said that, well, consider inherited disorders if there is a lot of family history, if you can't find anything else, it should be a rule out diagnosis. The most recent guidelines take it the other way. They suggest that 20% of patients have a family history, familial predisposition, and genetics should be a rule out rather than a rule in, and we'll take a look at what that means. So the big syndromic heritable connective tissue disorders that we need to consider: number one, Marfan's. This can be a never miss situation for our patients. This is a pathogenic mutation in FBN1 that encodes a connective tissue. And the clinical features associated with it include aortic aneurysm dissection, but also mitral valve prolapse. That's why echo is critical. Long bone overgrowth, scoliosis, myopia, tall stature. So this is a patient with Marfan syndrome. You can see the really long arm span here. So you can measure the arm span to height ratio. Next in the middle is the thumb sign. So this is overgrowth of fingers, and you can see that the thumb is sticking out from the palm. And then to the most right, this is the wrist sign. You take the first and the fifth digits, you wrap it around the wrist, and you can see that there is overlap in the digits. Again, overgrowth of bones. Try it yourself. Most likely you won't have something like this, but in your patients who you've seen for ascending aortic aneurysm, really important physical exam to do. Look for scoliosis, look for pectus carinatum or excavatum as well. That can give you a Beighton score, which we'll talk a little bit about as well, too. So the next disease to consider is the Loeys-Dietz syndrome. Now there's 5 well-known mutations that encode connective tissue here. This is TGFBR1, TGFBR2, TGF-beta2, TGF-beta3, and SMAD3. And this is obviously associated with aortic aneurysm and dissection, but the important diagnosis here, important difference between Loeys-Dietz and Marfan, and this can absolutely be tested on cardiology boards as well. I had a question about this. Is arterial tortuosity, bifid uvula, and bluish sclera. So I had a patient like this on my cardiology boards where somebody came in, a young woman came in with palpitations. She was incidentally discovered to have 4.5 centimeter ascending aortic aneurysm, and they showed a picture of blue sclera and said, what mutation do you expect? So absolutely testable. And this is the classic imaging here. So you can see cross-sectional imaging of the aorta, lots of tortuosity here. And you can see that the abdominal aorta is mildly aneurysmal. So this is classic for Loeys-Dietz. And on the right, I'm showing you here bifid uvula. So when was the last time as a cardiologist that you did an ENT exam? Well, maybe now you should. So look at somebody's sclera, look at their uvula. That can give you really important clues about what may be going on. And then the last one to consider is the vascular Ehlers-Danlos syndrome. This is less common in our cardiac practice, but something that if you're an aortic center, you will see as well too. This is a pathogenic mutation in COL3A1, and this is also associated with aortic aneurysm and dissection. But the big things to remember is this is bowel and uterine rupture. So these are the patients that, for example, this is a young woman who has multiple miscarriages in first trimester, then she goes on for a second trimester, third trimester, and then she comes in with a uterine rupture. Then when she undergoes emergent surgery, this is complicated by hypovolemic shock. You get a CTA and she has a hepatic aneurysm that has ruptured. Classic. I actually just saw a patient very similar to that scenario. So this is the classic patient with vascular Ehlers-Danlos. The carotid cavernous fistula is sort of that classic finding. You will not see that often. But the bowel and uterine rupture, that's really, really important, and you cannot miss that as a consideration for vascular Ehlers-Danlos. So these are the classic exam findings. You can see that their skin is really translucent. You can see the veins on their chest quite well. Their skin is very distensible. Look at that bleeding in their eyes. So that suggests microhemorrhages as well, which is common. And look at the short bone hyperinsensibility there with the fingers. So again, complete physical exam of these patients is critical. And that carotid cavernous fistula will give you that bulging red eye, and the patients may tell you, my eye pulsates. When you hear that, don't dismiss it. You should be thinking about carotid cavernous fistula. So when we think about joint hypermobility and the Beighton score, this is something that we can easily do for all of our patients in clinic. So that's showing you their thumb hypermobility in different ways, the elbow extension above 30 degrees, their knee extension, and then how they're able to put their uh, hands on the floor as well too. Now, 45, 60-year-old men and women with history of scoliosis and spine surgery and Marfan will not be able to do this, but young individuals will. So really make this part of your practice for physical exam in patients with ascending aortic aneurysm. So what about this bucket of familial thoracic aortic aneurysm? This is a bunch of genes, and it does not fit into heritable connective tissue disorder diagnosis. It's not those three disorders that we talked about. This is an autosomal dominant condition, but it's marked by variability in expression and penetrance. So it may be different in different generation, meaning some, it may be highly penetrant and you will see multiple aneurysms. Other generations, it won't be penetrant at all. And there's multiple possible mutations, but no common identified genes. And I've listed for you all these different types of mutations in familial thoracic aortic aneurysm that have been identified and are now part of our genetic panels. And there are some clinical features that are different for different genes. So for example, in ACTA2, they can have premature coronary artery disease or a Moyo-like cerebrovascular disease. Now, usually with ACTA2, the penetrance is different depending on the clinical features. So it is uncommon for a patient to have both aortic aneurysm dissection and premature CAD and Moyo-like disease. It's usually one versus all three, but it can express in different ways depending on the generation. MYH11 is the other one. The association usually is the PDA. MLK and PRKJ1 are really important to identify because usually they get aortic dissections at small aortic sizes. So these patients dissect at 4 centimeters, 4.2 centimeters. So these are critical patients to identify so you can prevent critical catastrophe here. And there is a lot more genes that are identified. There's about 30 to 35 genes that are included on genetics panels. So collaboration with genetics is paramount. And the genetic evaluation, as we talked about, when do I consider? Well, is there connective tissue disease features on the physical exam? Is there family history of other aneurysms? And when you talk about aneurysms, don't only ask, did your family have any other aortic aneurysms? Patients aren't going to know, but they are going to know if there was sudden cardiac death. And, I hear this all the time. Oh yeah, my dad died at 50. They said he had a heart attack. Okay, did he have prior heart attacks? No. How did he die? In his sleep? Did they do an autopsy? No. So that's not a heart attack. That should be an aortic dissection until you think otherwise. So ask about sudden cardiac death, aneurysms, including aortic aneurysms and cerebral aneurysms. And is the patient less than 60 years old? Now, it's different if the patient is 60 years old and has long-standing history of hypertension, for example. But if there's no other risk factors, really then consider genetic testing, not if that's 3 involved, but if any of the 3 are involved here. And then when you get genetic testing, there's different things that can happen. You can have a pathogenic mutation about 20% of the time, right? Or you can have a negative testing, which is way more common. If you have pathogenic mutation, then you can do testing for first-degree relatives for free, by the way, that the company does. If the genetic testing is negative, then you have to image relatives. So first-degree relatives. And there is a lot of family history, image second-degree relatives as well, too. So other etiologies to consider because, remember that's 20% of your patients. So what about the other 80? Well, bicuspid valves, something that we see quite commonly in our practice, coarctation of the aorta, congenital heart disease, history of PDA, hypertension, the most likely, atherosclerosis, prior aortic dissection, inflammatory disorders, so something that Nicole and I used to see quite a lot in vascular medicine practice, like giant cell arteritis that I showed you, Takayasu, but also don't forget Behçet's, IgG4, and sarcoid as well too. Infectious, something that we see less commonly these days, but still from third world countries. Syphilitic aortitis is one of the most common etiologies, and then traumatic as well too. Something that I want to mention to you that I'm not sure if you guys see this in your practice, but I see quite a bit and I think also important. And that's aorta in endurance athletes. So this is a study from a couple of years ago from JAMA Cardiology, which I think is such a cool study. And they imaged aortas in endurance athletes, rowers and runners. And what they saw is that a quarter of patients who are endurance athletes have aorta that is considered to be dilated. And that's both sinus of Valsalva as well as ascending aorta. But there are differences. If you're an elite competitor or rower, then you are more likely to have sinus of Valsalva dilation. Now the question comes up is, what's an elite competitor? Well, there is actually a specific definition. An elite competitor is somebody who competed in world championship or Olympics, or completion of a marathon under 2 hours and 45 minutes if you're a runner. So it's not that you like to run and do 5Ks here or there. This is true elite competitor. So you are more likely to have sinus of Valsalva dilation. If you have higher age or hypertension, then it's more likely that you have an ascending aortic dilation. But we see quite a lot of 4.2 centimeter runners or endurance athletes with sinus of Valsalva dilation. So think about this as etiology. The other cool finding, I think, is ascending aorta in former NFL players as well too, and we have quite a lot of these in our practice too. And this is a really nice study from Cirque from now almost 10 years ago, where they screened former NFL players and compared them to Dallas Heart Study. And what they saw is that the average ascending aorta in former NFL players was 3.8 centimeters. But again, that bell curve, many of these individuals, almost 30%, had aortas 4 centimeter or above, so abnormal. Compare that to the Dallas Heart Study, where the average mid-ascending aorta was 3.4 centimeters. The other really, I think, interesting thing is larger ascending aorta tends to be in lineman versus non-lineman, and predictors of ascending aorta dilation is age as well as BSA. So remember, again, aorta is not created equal. Think about different etiologies and compare to age and BSA as well too. So my takeaways for etiology is imaging does not equal physical exam. Now we think that echocardiogram replaces everything. Murmur, oh, let's get an echo. Echo, okay, that tells us what the murmur is going to be. It's become like a sixth vital sign. For aortic aneurysms, imaging does not equal physical exam, and full physical exam is critical. Detailed social and family history, really, really important. And medical genetics as a rule-out consult. Think about reasons why you will not get a medical genetics consultation versus rather than the reasons why you should. So then what about screening? Because we should be recommending screening. Should we be getting screening the general population? Well, there is no data that suggests that we should be doing that. What about first-degree relatives or sudden cardiac death? Absolutely. You should be screening first-degree relatives of patients with sudden cardiac death or aortic aneurysms. And then, like I said previously, even for second-degree relatives with extensive family history, multiple family members with aortic aneurysm or sudden cardiac death, recommend screening for second-degree relatives as well. How should we screen? By age 25 or 10 years before the youngest case. Really, really important. So if somebody was identified at age 20 or 15, you should be screening 10 years before the youngest case. Reimage at 5-year intervals if initial screening is normal. So it's not one and done, especially if you start screening at a younger age. Because remember, penetration is going to be different with each gene as well too. Screen the entire aorta once with CTA or MRA and evaluate the valves. Remember, with Marfan syndrome, you can have mitral valve prolapse. There's the mass phenotype where it's mostly expressed by mitral valve prolapse and then mitral regurgitation. So get, echo and cross-sectional imaging is important. So my approach is for patients, for surveillance is you get an echo. I always then get a one-time cross-sectional imaging of the chest, abdomen, pelvis. If there is initially cross-sectional imaging, then I get an echo. So then your options are there is concordance between aortic measurements or discordance, and then there's valve disease or no valve disease. Usually it tends to be either aortic regurgitation because of aortic aneurysm or mitral valve prolapse. So if you have concordance or no valvular disease, you can follow them with echocardiogram, and usually still I repeat cross-sectional imaging in about 5 years or so. If there's discordance, no valve disease, CTA or MRA, concordance and valve disease, follow with echo. Discordance and valve disease, well, you really need an echo as well as cross-sectional imaging. Here I say CTA, but you can do MRA as well if you have expertise at your center with it. Repeat first imaging at 6 months, and follow-up will depend on growth and etiology. Let's quickly go over imaging considerations in different connective tissue disorders, and this is what I pulled out from the guidelines. So class 1 recommendation, if you get an echo, repeat things at 6 months and then annually. If you can't see on echo, cross-sectional imaging is critical. But the class 2A recommendation, which we do here as well, get a cross-sectional imaging to confirm the diameter. What about Loeys-Dietz? Echo is important, but remember, these individuals have arterial branch aneurysms or dissection, so these individuals need to have annual cross-sectional imaging in addition to echo. And their baseline cross-sectional imaging should include head to pelvis because they can have intracranial aneurysms or dissection. If you don't have any dilation or dissections, you don't need to repeat it every year, but every 2 years. But this is critical. This is not just echo. What about bicuspid aortic valve? Echo, always your first step, but if you can't see the aorta well, CT or MRI. The other thing to consider is that bicuspid aortic valve may be part of the Loeys-Dietz syndrome. So again, physical exam is key, and think about Loeys-Dietz with somebody with bicuspid aortic valve, especially if there's bicuspid aortic and aortic involvement. Think about it, Loeys-Dietz, and then screen first-degree relatives. That's really, really important that I feel like we miss quite a bit. And it's even a class 2A indication to screen first-degree relatives if you just have a bicuspid aortic valve without aortic involvement as well too. And then with the sporadic or degenerative, echo at baseline, CT or MRI at baseline, and then surveillance with, as I talked about, either CT or cross-sectional imaging. Usually 6 months is your first step, and then every 1 to 2 years, depending on size and risk factors as well too. And then patients ask quite a bit, what is the expected rate of growth of these aneurysms? So I've given you a couple of studies here, but different studies will tell you differently. So there was a nice meta-analysis from a couple of years ago that suggested that the growth of ascending aortic aneurysms is really quite slow. For tricuspid aortic valve, it's 0.3 millimeters per year. For bicuspid, it's much higher. It's 0.7 millimeters per year. When you look at CT, it's even less. In men, it's 0.07 millimeters per year, but this is the important critical aspect here. Growth tends to be higher in women. It tends to be 0.1 millimeters per year. But still, it will take you multiple years to even grow 1 millimeter. So for bicuspid, it will take you a couple of years to grow 1 millimeter. For tricuspid, it takes 3 to 5 years. And there was a nice study recently in JACE as well, too, from Minneapolis that, again, confirmed that meta-analysis really. For tricuspid, it's really slow growth, 0.08 millimeters per year. For bicuspid, it's 0.4. So remember, be more cognizant of your bicuspid, be more cognizant of women as well, too. So establish the rate of growth, although that's not the whole story. And again, think about connective tissue disorders, family history. So the last point we will talk about here, and this by itself can be an hour lecture, is when do we fix this? So this is a classic study from 10 years ago now, which looked at natural history of aortic aneurysm dissection, rupture, or death. And they suggested that there is a sharp hinge point at 6 centimeters, and that's where the guidelines of 5.5 centimeters came from. You want to intervene before 6 centimeters. There's nothing crazy about this. Well, when you take a look at type A dissections, and this is frequency of type A dissections of a population, you see that, wow, obviously there's a bunch of population here where their aorta is 5.5 centimeters or above. Well, that's not surprising. But look at this, the majority of patients who had a type A dissection, actually 70%, had a type A dissection below the 5.5 centimeter surgical threshold. So we're missing a lot of patients. And yes, this is a 250 person study, but this has been reproduced in multiple population as well too. So I think something that is important for us to remember is that size matters, but not fully. So what I do quite a bit, and this is from 2018 classic study from Zafar and colleagues, is that I look and normalize to height, not even actually to the body surface area, to the height. And we do that on our CT and MRI reports. We provide measurements and then we provide standardization to height, because your risk of aortic dissection or aortic complication will depend if you're a 6'5", 65-year-old man or a 4'9", 35-year-old woman. So for example, if you take a look and you have a 5 centimeter aneurysm and you're 60 inches tall, your risk of dissection is actually pretty high. It's 12% per year. So do you really want to wait? Is it really that different waiting until 5.5 centimeter? Probably not. Then the other really important point to consider, and the guidelines do talk a little bit about this, is that aortic root dilation does not equal ascending aortic dilation. They're different pathophysiologies probably, and different risk of dissection. So this is a study from a couple of years ago, again, looking at population and dissection and their diameters of their mid-ascending aorta and lifetime risk of complications from the aortic. And you can see that threshold is really becomes at about 5 to 5.25 centimeter where that risk goes high. It's higher here probably because this is the heritable connective tissue disorders, people that were unidentified. Let's compare that to aortic root. Look at that. This upstick becomes higher much earlier on at probably about 4.5 centimeters. So aortic root aneurysm does not equal ascending aortic aneurysm. The other thing to consider, and this is more difficult, but it's great to try to do this in your own practice, is aortic length. So measuring ascending aorta from the aortic annulus to the origin of the innominate artery. And you can see here that when you normalize it to, when you take a look at ascending aortic length to probability of acute aortic events, there does seem to be a nice correlation at really 11.5 centimeters. But what does that mean again? Because we're all different heights. Well, that can be normalized and looked at height versus diameter of aortic aneurysm plus the length. And again, that can give you risk of aortic dissection over time. So a little bit harder to do in a busy clinical practice, but for patients in whom you're on the cusp thinking, what should I do? This doesn't seem right. Consider these things. Definitely normalize it to height, but think about looking at the length of the aorta as well too. So the guidelines will tell you that we should be fixing aortic aneurysms at 5.5 centimeters. It's a class 1A indication. But more than 5 centimeter, you should be considering. It's a class 2 indication, but what the guidelines will keep telling you, and this is really critical, this needs to be in experienced hands. So your surgeons should be familiar with aortic aneurysm repair, and you should be doing a lot of these if you want to be intervening at 5 centimeters or at 5 centimeters below the 5.5 centimeter threshold. Again, just like in carotid stenosis, asymptomatic, right? Your benefits need to be higher than the risk. So the risk of complications, you should know what that risk is, and every cardiac surgeon knows their risk. So again, become friends with your cardiac surgeon and know how many of these surgeries you're doing at your center. For Marfan syndrome, it is different, it is 5 centimeters or above if you don't have any high-risk features. But if you have high-risk features, including family history, diffuse aortic ascending aortic dilation, and vertebral artery tortuosity, so that's why I get that one-time screen 4.5 centimeters or above. Loeys-Dietz is a whole beast by itself. Different genetic variants will give you different diameters to fix. So again, this is where genetic evaluation becomes really, really important to identify the genetic abnormality. And again, that high-risk features, family history, tortuosity, sudden cardiac death. And then think about risk factors for mortality in ascending aortic aneurysms. This is something that we see every day in our cardiac practice, and we should not be taking this for granted. Hypertension, hyperlipidemia, and smoking. So goal blood pressure should be less than 120/80. I'm pretty active about their hyperlipidemia management, and cessation of smoking is critical, absolutely critical. So recognize that thresholds for fixing ascending aortic aneurysm differ based on multiple factors. So that case, remember that I talked to you about, that case to conclusion, that was a 49-year-old woman with pathogenic FBN1 mutation. Her mother had aortic dissection in her 40s. She was started on metoprolol-succinate and losartan, and she consequently underwent a valve-sparing aortic root replacement with 30 millimeter salva graft, and is doing really well at this point. So in summary, multidisciplinary comprehensive evaluation is key. Cardiology, genetics, vascular surgery, cardiac surgery. Don't just rely on imaging. Yes, imaging is critical, but physical exam is as critical as imaging. Regular follow-up and control of risk factors is very important. This should not be a one-and-done consult. You should be seeing these patients annually. And then shared decision-making about timing of surgery. We still don't truly understand which individuals benefit the most from earlier surgery if they don't have a pathogenic mutation versus earlier surgery. So this is a shared decision-making. And it's a tough one because aortic aneurysms are asymptomatic until they're not. So this is going to be sternotomy. So telling patients that they need to undergo sternotomy when they feel great, especially athletes, is tough. So this is a really shared decision-making with surgical colleagues and us in cardiovascular medicine. Thank you for your attention. I love talking about this topic, and I'll be happy to answer any questions.
Thank you so much, Dr. Henkin, for that great talk. We do have a couple of questions that are coming into the chat. Dr. Patel, she says, thank you for your wonderful presentation. Do surveillance guidelines for bicuspid aortic valve apply to a functional bicuspid aortic valve with complete or partial fusion of cusps?
Yeah, so that's a really good question. And the guidelines don't really distinguish those. I do think, and if you even take a look at the studies, they don't distinguish that, which is really important. So that's why I think also there is a difference in aortic growth over time. In my experience doing this now for almost 10 years or so, it seems that, complete fusion of cusp, they tend to grow faster than partial fusion of cusps, even faster than functional BAVs. But again, when you take a look at the guidelines, they don't distinguish those at all. So my suggestion is start with that 6-month, see what happens, go to annual for a couple of years. And if nothing happens, again, guidelines are just suggestions that we should be following. It does not take over our clinical expertise as well, too. So if somebody has been stable for multiple years following annually, it's okay to go every other year or every 3 to 5 years, especially in degenerative valves, too. And then there's a question about Turner syndrome.
Yes.
Yeah, so it's interesting because I had this conversation with my congenital colleagues, Turner syndrome and GH therapy, and from what they told me, they have not seen that GH therapy reduces the rate of expansion. Again, I actually don't know studies about that. That's something I will look up. But at least here, we surveil these individuals and fix them at the same recommendations as those who don't get GH therapy. But that's a really good question. I would follow them the same for now, at least.
Wonderful. Thank you, Dr. Henkin. Another question coming in from Dr. Joven. What are the recommendations for surveillance imaging post-repair?
Really good question. So what we do is we get CTA 6 months after, so we get it at hospital prior to hospital dismissal. Then we get it at 6 months, and then usually at 18 months if everything looks good. And then usually we're done with cross-sectional imaging. Now that's very different depending on was the valve fixed or not as well too. If it was fixed, then we usually do get an annual or at most every 2 years echo. And then the other consideration is what was the etiology of aneurysm as well. If it was heritable tissue, connective tissue, you need to surveil them as you would still for other aneurysms regularly. But if it was a degenerative aneurysm, their valve looked fine, you fixed it, usually
I think
6 months, 18 months, and you're done.
Excellent. Thank you so much. I think we have 3 more questions. If you have time, is that all right?
Absolutely. Yeah, so I see the question about the high endurance, high intensity hobbies. That's an awesome question. So you know, I've had this conversation with some of my professional athletes that are retired. And some of, a bunch of them have children, then have gone on to go into professional sports, including NFL and NBA. And I always ask this question of, so during NFL Combine, and I don't know this answer because I'm not, by definition, a sports cardiologist, so I'm not there, but do they get echoes as part of their physical? And I don't know the answer to that because I keep telling them your kids should be getting echoes, but this is also their livelihood as well. And so recommending that and then finding it is, becomes a challenge because now you're talking about millions of dollars in contract, and dealing with that as a cardiologist is tough, honestly. It becomes very political. But I think in general, in high endurance athletes, Olympic athletes, weightlifters especially, you may have seen videos, gruesome videos on YouTube where Olympic weightlifter lifted, syncopized, died. That was aortic dissection. There's multiple instances like that. So in my opinion, if you are truly an endurance athlete, and that's NFL, runner, rugby, rower, we should be screening those individuals, especially as they get older or have other risk factors. And they have in general higher risk of, atrial fibrillation and things like that too. So they get echoes down the line. But should we be screening them earlier? Maybe.
That rolls really nicely into our next question. That for patients with the ascending aortic aneurysms, do you provide restrictions for certain physical activities, heavy lifting? How do you counsel patients in that regard?
Oh, I love that question because this is Nicole has been with me seeing these patients. This is probably one of my biggest pet peeve because I see these patients and they have been told, young men and women, that they cannot be weightlifting more than 10 pounds, and so what I say is that, my gosh, we tell you not to exercise, not to weightlift, and now you become sedentary, overweight, and you have a heart attack. That is the worst thing that we can do as a cardiologist. There is absolutely zero studies, zero, that take a look at a specific weight lifted and the risk of aortic aneurysm or dissection. We have actually a weightlifting study at Mayo right now that we're trying to figure out this, but there is zero research. So the way that we talk about this is you need to avoid weightlifting or physical activity that makes you valsalva or hold your breath or strain. So that's going to be different depending on a different person. And what I tell my younger individuals is that focus on the reps rather than focus on the PR, right? So if you're trying to bench 300 pounds for one, probably shouldn't be doing that. But if you can do 20 reps at 120, great. Don't go to that max, go to that wear out, almost strain, and then stop. So don't valsalva, don't strain. In terms of cardiac training, don't get dehydrated. And activities in general, you should be limiting them to where you can have a theoretical conversation with somebody next to you. Why is that? Because when somebody is breathing so hard, right, their meds are going to be so high, that means that their heart rate and blood pressure are going to be super high as well. So we talk in generalities and common sense. It's not restrictions, common sense things rather than specific restrictions, because it's very different depending on population. For some individuals, carrying groceries is tough enough. So I'm not going to tell them that they can't weight lift more than 10 pounds because 2 pounds is too much for them. So talk about sort of generalities because it will be different for every different person.
Thank you so much.
And the role of statins as well too. So the role of statins is actually quite different in AAAs than thoracic aortic aneurysms, because the pathophysiology is probably different in degenerative, especially since thoracics 20% are heritable. So in those with heritable connective tissue disorders, statins probably don't do much. It does seem that statins, due to their anti-inflammatory effect, do reduce the risk of growth of abdominal aortic aneurysms. And in those with degenerative ascending and descending, statins are important as part of overall cardiovascular health prevention, but hypertension is the most important thing. But if you have a reason to give somebody statin, I will never say no to a statin. You know, that's why imaging, looking for aortic plaque, coronary artery plaque, you know, those that will all they'll be given to you. You can see it on CT imaging. So in thoracic aortic aneurysm, unless I have a reason to, I don't. In abdominal aortic aneurysms, I do.
Excellent. And I think there is just one more question, which is what is the size of the residual arch following hemiarch replacement for when innervation is recommended?
So usually this is going to be a reduced sternotomy, so we wait a little bit more. So for these individuals, we do wait until the arch is 6 centimeters usually, unless there's high risk features. Again, family history, connective tissue disorders, younger patients, but since it tends to be a redo, we tend to be less aggressive in these patients unless we worry about them. Now, something that I would suggest for an institution, if you have an aortic center, you think about aortic center, I sort of talk about multidisciplinary management. And so what does that mean? Because we see patients at different time points, right? So my consultation is going to be different than genetics, is going to be different than cardiac surgery or vascular surgery. So every Thursday at 5 p.m., we have an aortic discussion where we meet online and in the room, and it's a combination of radiology, cardiac surgery, vascular surgery, anesthesia, cardiology. And we talk about patients that are difficult, on the cusp of repair, we don't know what to do. And this is an enterprise-wide conference. That means not only Mayo Rochester, but Mayo Arizona and Mayo Florida. And so we make decisions as truly, we kind of do it as, you know, how hematology and oncology has their, their panels that decide management. We do that for aortas as well, too. And you guys do that for TAVRs, you know, and mitral valves and tricuspids. You know, you get everybody in the room at the same time. We do the same thing for aortas, and we should be. So, you know, we truly do have multidisciplinary management. And we talk about that with patients. We'll say, I'm going to talk about your case, you know, this week, and I will come back to you with the decision of our panel. And so it truly is sort of decision that we make together, and not only one of us has to take on the brunt of the decision, because I also don't want to refer to a patient to cardiac surgery and say you're going to have surgery when there are some technical considerations that are being considered that I don't understand. So this again gets everybody in the room together, and we talk about many different things. And actually, I find the most helpful in the room is radiologist, personally, is because we bring up the imaging and we measure the same way each time, and we have the same radiologist, and we remeasure in multiple time points, and it's just such an awesome learning experience. So if you ever have this ability to do that as a fellow, I would really invite you to do that.
Wonderful. Dr. Henkin, thank you again for an excellent talk. In the interest of time, I think we will probably...
Hey, Dr. Henkin, can you repeat your answer about the bicuspid valve? I missed the full answer.
Annually for the first several years.
Doesn't matter if it's partial, the fusion doesn't matter, right?
For now, we don't have data that it matters. Down the line, I know there are studies looking at this, it does, but for now, we don't have a distinction between the two.
But you think that the congenital bicuspid is probably more likely to be a problem, is what I heard you say?
Definitely. I think the congenital bicuspid are much more likely to be a problem. That's right.
Thank you.
You're welcome.
Excellent. Thank you so much again, Dr. Henkin, and thank you everyone for joining today.
Thanks, everybody.
Yep.